Good evening, everyone. It's just 1 p.m., so please permit me to start this session. This is the Symposium Session 1, Fidelity and Quality Measures for First Episode Psychosis Services. As you have already known that fidelity scale and outcome measurement is very, very essential and fundamental for implementing the early intervention service. And the task force have studied about this development twice in these 2 years and have a conference, some kind of a study group. And today we have the review of these progress of the discussion here. So the first speaker is, this morning we have Angelo Cocchi award presentation, and the first presenter is the awardee of this prize, Professor Donald Addington from Calgary. So Don, please have your lecture.
So good afternoon, everybody. I'm presenting a bit of an overview and summary presentation of the work of the International Early Psychosis Association Task Force. So I don't have any pharmaceutical company conflicts of interest. And this is a picture of our group. There was a picture shown this morning, but this names names. So perhaps some of the usual suspects here: Max Birchwood from left to right, Peter Jones, Marriott Nordentoft, Marianne Malo, Kim Musak, Donald Addington, David McDade, Masafumi Musunu. Ian Kilaki was invisible on Skype. So this is just a sort of summary slide to look at what some people call knowledge synthesis tools. There's a variety of things we can do that all build on research information. So at the bottom, you've got the research, and that's why it fits well with looking backwards, looking forwards. There's a lot of data and information that we can build on to do, to use to develop tools. Clinical practice guidelines are driven by research. Risk prediction algorithms, we heard about the Naples individual risk algorithm, which was presented. Fidelity scales and performance measures, which is what we're talking about today. Risk adjustment algorithms, you can develop an algorithm with the view to comparing programs that are dissimilar just by adjusting for baseline characteristics of the population. It's difficult to get grants to do research because the researchers think this isn't strong enough, but it's done a great deal in terms of comparing outcomes in different regions, in different countries, in healthcare generally. So, as I said, today we're talking about that accountability is really important in healthcare generally, in mental health care. We want to get resources and be accountable, and in the long run we're aiming at improved outcomes. So that's the big picture. So what is program fidelity? It's the degree of implementation of an evidence-based practice, and generally by agreement it focuses on measure of structure and process, not outcome. So do you have somebody who is skilled in CBT, as we were hearing about in the Italian program? Can you get them to meet with patients and deliver a number of sessions? A performance measurement measure is a quantitative tool such as a rate, ratio, or percentage that provides an indication of an organization's performance in relation to a specific process or outcome. And so you can focus on an early psychosis program, you can focus on a schizophrenia program, you can focus on youth mental health, or your national mental health program. This is a definition that comes from JCAHO, which now has a new name, which is the US accreditation agency, and is applied generally in healthcare. Okay. All right, I'm not moving ahead here. Sorry. I noticed that there was a problem with this morning. Thank you. So, just the goals and objectives. So if you want to measure something, you really want to know what it is you're trying to achieve. And so if the goal of, very broadly, of first episode psychosis services is to improve quality of life for patients and family, then you can break it down into some of the more specific objectives. Early intervention, how do you get people early on? It's got to be easy to get in. Sustain engagement and retention. Nothing will happen unless you can have all sorts of good treatments, but if you don't keep them engaged, there's a focus on recovery, inclusion of family and natural supports. You want integrated evidence-based psychosocial and pharmacological treatments. We heard a bit about this morning about past standard care in Italy, where there was a tendency to emphasize biological treatments, pharmacological, and then there needs to be an accountability for outcomes. So we looked at published performance measures and looked to try and get a nice and smallish number of key performance measures. We heard from Bob Heinzen this morning. SAMHSA has been working on a similar project to identify some key performance measures and maybe collect them broadly across the US. I don't actually know what's all of the bits and pieces in their toolkit, but we went for ones that are fairly easily measurable, can be measured in non-specialized mental health services. And so we found 4 early intervention measures that target, whether or not that's happening, 5 patient outcome related measures, and 4 health and safety measures. They all are simple and readily available. That doesn't mean it's easy to collect given health systems. Generally, mental health systems are behind the rest of health systems in collecting and organizing measures in a systematic way. So these were the performance measures that we identified for early intervention. So first one was the proportion of patients seen within the first 2 weeks of referral. And there's, in fact, more detail to this. And for those who are interested, I think if you look at the NICE pathways and measures, which is the National Institutes of Clinical Health Excellence in the UK, they have put together a very detailed, reliable description. One of the things about performance measurement in the health system is you don't want things gameable. It's a very important practical issue. So that's measured there. The median duration of untreated psychosis, which we've all heard a lot about. It's perhaps not the most reliable of measures, but it can be measured, and it is meaningful at one level, even if it's not quite as precise as some researchers would like. Then there's the proportion of estimated annual incident cases enrolled. We saw a nice example of that being addressed in the piano study. They had a prediction of how many cases to expect. Thank you. Finally, the proportion of new referrals to first episode psychosis that first admitted to an inpatient service prior to referral. One of the biggest predictors of future hospitalization generally is past hospitalization, and if you can avoid that first hospitalization, you can generally get better results. I think Ray's, and I don't know quite why, didn't find that, but that's been, other studies have suggested that. So those were the early intervention measures. Are we really intervening early? And they're two separate issues. You can provide excellent clinical care, but a little bit down the road, or you can really go for both early intervention and excellent clinical care. So patient outcome measures the proportion of patients retained in follow-up at 1, 2, and 3 years, and that's 1%. And for example, we heard in Italy, again, this was already very good for routine mental health services. So then it's a challenge for early psychosis services to do better. But in many other systems, the routine care isn't retaining 80% at 2 years. That's very high. The proportion of patients with at least one hospital admission at 1, 2, and 3 years is important. The proportion of patients participating in education and the group participating in employment. You don't need to have researchers and specially trained clinicians to measure these things. You need special clinician training to deliver the care, and that's what they're most interested in. And it's always difficult to get them to collect more detailed sort of research kind of measures. So finally, health and safety. We know very well that our patients have a much shorter lifespan, and it's important early on to begin to pay attention to that. And so these were the measures that are being widely discussed in a variety of settings as what can be done. The proportion with antipsychotic medication doses within national guidelines. There's a very nice paper from the RAISE study that discusses medication. They had a medication algorithm built into that research protocol. The proportion with documented assessment of tardive dyskinesia. That's dropped off the radar a little bit because of it's less common than it used to be, but it's still there and still a problem, and it's measurable. The proportion with documented BMI, that's a simple measure that can be done fairly easily. Documented suicide attempts and documented monitoring of metabolic parameters, and we tend to think of that as glucose and lipids as well. So that's the performance measurement framework. Looking at Fidelity scale, we've discussed this. It's a scale that measures fidelity and provides a list of objective criteria by which a program or intervention is judged to adhere to a reference standard for the intervention. So you've got to say what it needs to deliver and how you actually assess that it's delivering it or not. And there's two ways of doing it. One is to take an effective program, for example, one that's been researched and shown to be effective, as in the OPUS program, and you build it around, well, this is what we did in OPUS, and this is what we're going to do. Or you can do it on a literature review of multiple programs and program components. And we developed in Calgary one. It was developed in Canada and the US that's more generic. So this is the list of scales that we identified. And 2 years ago, I did a presentation that there was only 4 on this list. So clearly, there's work being done on this, and it's a progressive work. It's not finished or done. So there's the first episode psychosis services Fidelity scale, which is the generic one, early intervention service EIS scale from the UK, the Danish one based on Opus. We heard about the RAISE scale that's been applied in the US this morning, and the ESA one is from Oregon. We heard that Oregon was the first state to have a network of programs, and as part of their implementation, they developed their own Fidelity scale. And they were collaborators in the development of the first episode psychosis. And there's one that's been used in Australia for the rollout of federal funding there. So there are plenty of measures. We looked at some of the items that were common to the 6 Fidelity scale, and this is the list. It was very encouraging that there is a kind of consensus on core Fidelity components that can be measured. They may be measuring them in slightly different ways, but it would be disappointing if they all look different. So the conclusions to this sort of very encapsulated bit, which is a list of things, that Fidelity scales and performance measures are available. They can support implementation. They can support quality assurance, measuring access and quality. And they can be applied very effectively in research that we need to go ahead and find out in a more sophisticated way what are the elements and components. How do we build in, because if you look at specific programs, they often offer certain elements and not others. So do they offer supported employment? In the US they do, and in Italy I think not, sort of, maybe. So I think there's a lot of potential to collect this kind of information. It's exciting to hear that in the US they're looking at a network of programs that maybe can link this to large data analyses. So thank you. That's my presentation, and we may have a time for 1 or 2 questions, and otherwise we'll be presenting in turn.
Are there any questions for Don Erlington? Yeah, please speak up.
Yes, there are, and that's, I haven't got into the detail in any way in any of these measures, but you, for the most part, you score them from 1 to 4 or 5, and there's a variable proportion. So, for example, so there's the measure, and so you've got the STEM, for example, the proportion seen within 2 weeks, and then you might get, if it's 20%, then you get a 1 for that. If it's 30%, you get a 2. The UK has set, United Kingdom has set a standard for 50% being seen within 2 weeks. And so on a Fidelity scale, you'd want to put that up at a level. So, but that, and making that determination, how many sessions of family education and support is required, it's very helpful to have the data that we saw from the piano study on the actual number that were delivered. And then you can do secondary data analyses of that project. Well, how many maybe made a difference? What was there a minimum or a maximum? Because we often don't have what's called a dose-response curve for psychosocial interventions. So you look at a lot of research studies and you juggle, and there's a bit of judgment in all of that. But I think there is reliable data to give us some guidance on that. And as you continue to use the research, the fidelity scales, and you get feedback and say, well, maybe everybody is fine on this. For example, we may learn that if you can lower doses below the national recommendations for pharmacotherapy, maybe there are some potential benefits, but you need to collect that kind of information.
Yeah, thank you, Don.
So the third speaker is Marianne Mello from Denmark and the OPAS team of Copenhagen. So her title is Program Fidelity of Specialized Early Intervention Service in Denmark. She's a person in charge for developing the fidelity of their team. In my opinion, their scale is very, how can I say, very compatible for the clinical use and includes common devices well. So, please.
Thank you for your presentation. Thank you. I'm very glad to be here today to present our study of fidelity in Denmark. And I also will start out telling you about a little bit about the development of the Danish fidelity scale. But first, is it really important to talk about fidelity? What is all this fuss about it? Does it really matter? And yes, we think it's matter a great deal because we are all in a way consumers, and we need to be to trust that what we are promising, what we are expecting to find in the product is also what we are getting. In other words, will there be tomato in the tomato ketchups? And will there be a lot? So the fidelity scales, I think, Don already told us about both the scales and what are we talking about when we talk about fidelity. So I say something about the background for developing the scale in Denmark. We all know that the efficacy of the specialized early intervention treatment has proven to be very strong compared to treatment as usual. And during the last 18 years, dissemination of the teams has been increased in Denmark. And we think that a prerequisite for upholding positive effects is to preserve those critical and evidence-based components. And they are listed here, and I think we are all very familiar with this list about the multidisciplinary team, the assertive community treatment, assertive outreach, and so on. We find that there will be a possibility that a fidelity scale could be an important tool for ensuring the quality of early intervention treatment in Denmark. And it might also serve as a guideline and prototype for policymakers in future budget planning and organization of new teams in Denmark. And it also is very useful in the matter of research. This is a picture where you can see it's a picture of Denmark, and the large red spot covering our capital city, Copenhagen, and the bit minor red spot covered another large city in Denmark called Aarhus. And back in 1998, there were only a few experimental teams located in the two largest cities in Denmark. And today, we have as many as 23 teams. They have different. They all have a catchment area for 100 to 200 inhabitants. But as you can see here, here in the capital area, where people are living very close to each other, we have as many as 11 early intervention teams. And another part of Denmark, the northern part of Denmark, it is all only covered by one team. And it's of course because people are living more spread out in the area. And it has some implication, and I will go back to these later in my talk. Our development of the scale was, we did that during the last couple of years, and we will follow different steps. But all in all, it was, you can call it an adapted Delphi consensus process. As we wanted the scale to be short and easy to manage, we did not include factors in the scale which were already mandatory in the Danish quality standard for mental health care. For example, assessment and diagnosis by expert, low doses of antipsychotic medication, and monitoring and metabolic risk factor and suicidal behavior. And we ended up with a scale of 18 critical components divided into two dimensions, one covering the structure of the teams and one covered the character and content of the treatment. Each component can be rated either 1 or 0 with a maximum score of 18 points, of which 5 of the components are mandatory. And those are independent management, multidisciplinary team, low caseload, not more than 12 in average, assertive outreach, and systematic engagement of family and relatives. The other 13 items of the scale were team sites, team meetings, level of staff education, training and education of the staff, supervision, and also the localization of the team. For those concerning the content of the treatment, there were flexibility and easy accessibility, emphasis of the client's views, cognitive case management and/or cognitive behavioral therapy, and also the fact that the team were responsible for identifying and acting in relation to social condition, personal condition, and drug and alcohol misuse. And also, very important, that the group offering different programs to support recovery included multiple family groups and social skills training. The assessment of the scale, you can reach the level of fidelity at an elite level, where the total score will be between 16 and 18 and the present of all mandatory components, or at an adequate level, where the total score will be 15 and the present of at least 4 of the 5 mandatory components. Okay, so now I'm going to tell you about the test of this scale and how we map the fidelity in Denmark. This is a flow of the participating teams. As many as 23 were invited to participate in the trial, in the study, and one team declined to participate, leave us with 22 teams, of which 20 of the teams were visit and data collected in person, and 2 of the teams we collect data from by telephone interview. We used multiple data sources, among others, interview with team leaders, 2 staff members, with 2 patients, and also we observed a team meeting. Furthermore, we collected local characteristics of the teams, the date of establishment, duration of the treatment offered, diagnosis and age, number of patient and staff members at the moment, staff qualification, education, and number of staff with a cognitive therapeutic training. After completing the assessment, each team will receive a written Fidelity feedback report covering which data sources has been used for assessed each item, and of course the overall Fidelity score for the team. Data was collected between May and October this year. Last team was visited only 2 weeks ago, and each visit was around 1 and 1.5 days. And here you can see a lot of doors, and those are entrance to some of the teams we visit. Yes, and now to some of the results. The first figure here covers the total level of the Fidelity, and as many as 18% reached Fidelity at an elite level, and as many as 46% reached the level at an adequate level, meaning that 64% reached Fidelity all in all. And it's rather good, as we think, but what about the rest? And I show you some of the results in this figure, this bar charts, where you can see it's a structure, it's an item covering the structure of the scale, and all the green bars are those who fulfilled the requirement for each item, and the red bars are those who did not fulfill the requirement for the items. For example, 27% did not have an independent management, meaning that, for example, they could not engage new case manager or team member themselves. And here you can see 32% were having a caseload more than 12 in average. And those large bar you can see here covered the item of training and education and supervision. And it's not that the team did not have any supervision. They offered usually supervision to the case manager on the function of case management. And it's not that they do not train and educate their team member, but what they don't do, they are not having any training and education concerning multiple family groups or social skills training, and the same goes for the supervision. And it's actually a way to safeguard the concept in the long run, we think. Okay, what about the result for the treatment? It's a complete different picture. Here you can see a lot of green bars, meaning that almost every team fulfilled the requirement according to the items of the content of the treatment. And it means that despite difficulty about the structure, the team and the case management are doing a very good job. And these items are also what patients find very important in the early intervention. They are talking about the importance of assertive outreach, flexibility, offering group programs, and the engagement of relatives. Okay. Now we are, of course, going to evaluate and refine the scale. We have to ask ourselves, are we assessing the right items? Could we involve patient and relatives even more in the fidelity assessment? Could the tool be used, could the scale be used as a tool for teams to assess their own fidelity, or as a tool for reciprocally assessment between the teams? Or are the level of fidelity associated with outcomes? So in conclusion, when we have refined the scale, I think we can agree that the scale was proving to be useful as an assessment of the scale across different teams. There was a high degree of fidelity with respect to the content of the treatment, and there were large individual team differences in fidelity of the structure. And some of them were due to logistical challenge. And I want to use a minute to say something about the logistical challenge. Here you can see the part of Northern Jutland. And all the colored spots here represent a case manager. And you can see where the patient they are going to visit are living. They are living very closely. It's the city of Aalborg. And this picture, you can see it's the same case manager, and it's the same team. And they are also, besides visiting patient in the city, they are going to visit or have responsibility for patient and relatives living very far in distance. And it is not the only part of Denmark where this picture is true. We know this from other parts, and they are doing a very great job to make sure that every patient and relative are getting as good as treatment as possible. But of course, there is something which is different. They are driving a lot in cars, and they are sitting in office around the countryside, and they are also using online-psychiatry some places. But what about offering the multifamily groups and the social skills training and the groups where the patient can meet other patients? It can be very difficult when they are living far from the team's location. So what about a bus, a specialized early intervention on wheels, which can drive around, hosting groups and and being intervention on wheels? Okay. At last, I want to say very warm thanks to all the teams participating in this study, to all the patients, and to all the team members. And thank you for your attention.
Yes, thank you, Marianne. Is there any questions from the audience to this presentation? You can have this one.
Hi, thanks for the talk. I'm from Canada, Northern Ontario, where we have a region, I'm servicing a region very similar to that very last bit that you were talking about. So we have like 0.4 of a person in a square kilometer. That's how sparsely. And I've struggled a lot with, in terms of the model of the EI service that we are delivering, because you talk about the hub and spoke, where you have the core center and you have one or two
Yes.
FTEs scattered across, versus the traveling team, where the team is in the middle and you sort of do the outreach across, through video conferencing, etc. How do you find the fidelity of these teams that are servicing these rural areas? Are they meeting fidelity standards, or are they not because of the logistical issues?
Some are and some are not. And I think some of the answer is depending on more structural political issues, local culture, and so on. But you can't say that it's the same in level of fidelity. It's not.
Hi, thanks for a very interesting talk. I'm just going with yourself and Peter's talk before you. I'm thinking, you're saying that a lot of the problems were purely structural fidelity, but when you looked at outcomes, outcome and content, they were very similar. And I'm just wondering, would you have the data within the teams to check out what's important in terms of structural fidelity? In other words, does it make a difference to outcome, and could that really inform us a lot about maybe having a multitude of different types of teams that suit different areas?
Thank you for the question. I think it's a very important question, and I can't answer right here because we only get the data 2 weeks ago. But I think it will be very interesting and to look into those differences between the teams. But I can't answer you here and now.
Could I just make a comment on that, on Maurice Gervin's point, that I think it is a very interesting idea that, and it goes back to separating structures from functions. So a lot of policy in, I guess, most countries comes from cities. And
Yes.
in England, it's
Yeah.
largely South London, Birmingham or Manchester.
Yeah.
And the models are very applicable in those inner cities, but the further you move away from that straight line, the less generalizable the data are.
Yes.
And it may well be that we should solve the
Yes.
problem in different ways in different
Yes. You
parts
can't
of the
ask,
country.
is it fair to use the same fidelity scale in both areas? Is it fair? Yes.
Okay, thank you so much. And now, now we move on to the last speaker in this symposium. It's David McDade, who is going to talk about economy. He's a health economist. So.
Good afternoon, everyone. Yes, I'm here to talk about money and economics. But actually, I'm going to talk about fidelity, but in a slightly different way to the other speakers, because I'm not really going to talk about scales, but I'm going to talk more about the whole challenge of, okay, let's say you have a perfect fidelity instrument. How is that actually going to be used? How is that actually going to make a difference? If you have a perfect fidelity instrument, are people actually going to implement perfect services? How do you make them implement perfect services? Can that be done? And so that's really what I'm going to focus on and think about some sort of economic issues around that and actually raise questions for you potentially to put into your research going forward. And I'm doing that within the context of some work that we've done in London really looking at the different kind of models of early intervention services in high-income countries, predominantly European countries, but we also looked at Australia and Canada in particular as well. And we were looking at really the way in which they're structured, what's known about cost effectiveness, and then these issues about, well, why don't things work the way you would expect them to? What do we know about barriers? And I'm talking here about economic barriers, systems barriers, and also facilitators. Now, there is actually a report that's available from the LSE. I should also say that the work was supported by an unconditional grant from Otsuka and the Lundbeck Foundation, and most of what I'm talking about draws on findings from this report. So really what we did, we tried to do a systematic review in the sense of looking for published academic papers and identifying early intervention services linked to those papers. We also did a kind of a website mapping analysis, looking, for instance, at the IEPA website and seeing the links there, and looking at various other ways in which to sort of identify what's going on in different countries. We were trying to map as well the extent to which key components of EI services are in place within programs, looking for innovative approaches. So, for instance, we can identify from the programs we found programs that try and deliver more telehealth services over larger areas because of the geographical challenges. And really, so that's what we've been doing. We're sort of doing documentary analysis of what sort of programs are out there, what are the key components, how do they differ, and really sort of trying to understand some things about that. I'm not going to go through that in detail today because we don't have time, but just to say that really one of the challenges, I see it from an economics point of view and a health economics point of view, is that it's still relatively few countries that have really embraced early intervention in terms of specialist early intervention teams. We're talking a handful of countries in Europe, Great Britain, England, Scotland, Wales, the Netherlands, Denmark, Switzerland, Norway, Iceland, although Iceland is perhaps a strange example because I think there's only one or two teams, but there aren't that many people in Iceland, so it sort of covers the country. And then you'll find, of course, most of the states of Australia, some of the provinces in Canada, New Zealand, Hong Kong as well as another example. But really, it's a relatively limited number of countries where the United States, of course, parts of the US, but it's a relatively limited number of countries where the model has been embraced. And what I find quite striking is there's a large number of European countries where relatively modest amounts of work are going on. And I think it's also fair to say that the existence of programs, you can point to slides or point to documents saying we have 20 or 30 teams existing in a country, but they may not be actually EI teams as you may expect them to be. They may not be fully staffed. They may actually have additional functions and be covering additional patient groups. So you have to really sort of delve into the detail to actually understand what's going on. And what's the one sort of take-home message at a very simplistic overview level here at the moment is that really when it comes, you've got key clinical basic components that you'll see in most programs, but when it comes to vocational support for people to complete their education, support for physical health, actually, such an important and vital part of life, as Don was saying in his talk, they are much more limited in the way in which they're actually covered by programs. So the UK is a good example, or GB is a good example. Lots of programs, but many of these programs do have a wide set of services that they cover, including issues around housing, employment, etc. But these programs have been under pressure. And one of our NGOs in the UK, Rethink, was talking 2 or 3 years ago now about 50% of services having to contend with the challenge of budgetary cuts. And of course, we're in a system where there are lots of budgetary challenges at the moment, and they're probably going to get worse with Brexit, but that's for another day. But it's just really the point that even when programs are in place, you need to have careful interpretation as to what those programs actually are and what they're doing, which is why Fidelity is so important, and using Fidelity checklists to actually understand the programs themselves. So going back to what's actually available, again, sort of this stylized map of Europe. I mean, I find it quite interesting that places like France, for instance, there are very few specialist EI programs really about in the country, 1 or 2 in Paris and 1 or 2 other places. But it's that model hasn't really taken off in the French system. I stand to be corrected, but that's my understanding of things. in countries in yellow here, places like Spain and Belgium, Ireland, Sweden, etc., there are programs, Germany even, but it's much more, in many cases, linked to research funding, particularly in places like Spain, where programs are absolutely dependent on time-limited research funds for their continuation. And you'll only really find programs in large cities and with a relatively limited number of individuals they can cover. Even in Italy, where we had the tremendous pioneering work of Angelo Cocci and the Programma 2000 here in Milan, actually the programs themselves were pretty modest in scale and size, although there were lots of them certainly in northern Italy. And really, so lots of challenges. Things haven't taken off everywhere, and some of this is around system structures, some of it is around incentives, some of it's around the way in which specialist mental health care is funded. But it basically means that when we think about fidelity, in my view, it's not just about the actual principal components of what a program delivers, but it's understanding how it fits within a system. So can we, for instance, if we're thinking about France as a model, would we expect to do the same kind of thing in France as we do in some other European countries, or does it have to be adapted to a way that can work better in France? We've heard about the work that's been done now in northern Italy with a piano study, which is about embedding specialist skills within community mental health teams. It's a different approach to expanding access to first episode services. That's another model to think about and consider as well. I won't worry about research now, but I just want to say a few things about the economic case, particularly focusing on issues around fidelity. First of all, to say, well, okay, economists, we can point to studies saying that it is worth investing in early intervention programs in some countries and in some contexts. So we can point to cost-effectiveness studies in places like Australia, the UK, Denmark, the Nordic countries, and many of those studies, when they talk about cost effectiveness, they do embrace and adopt this broader societal perspective. So they don't just think about impacts in terms of clinical functioning, but also social functioning. And often the return on investment from an economic point of view is because of these benefits outside of the healthcare system as well. And that's something to think about as well with fidelity scales, the extent to which they actually think about those issues. But what there's been very little of, with the exception really of the study that Peter was talking about, that Peter was involved in with Paul McCrone, and I can never say the first author's name, but that's my fault. But the Peter study is a very important pioneering study looking at the economic case for investing in better fidelity itself. Is it worth spending more money to actually promote better quality, I suppose, or better adherence to the principles of EI? And that's a really important thing to look at. And I should say more generally in the area of mental health research, this is an area that is now starting to develop. If you do a Medline search or for fidelity and cost effectiveness, you'll pick up a number of papers starting to look at this specific issue. Perhaps it's also linked to the issue of implementation science as well, better implementation, but this kind of interface between clinical fidelity and fidelity in implementation itself. And it's important because, these things do cost money and lots of money. And there are potential benefits. Again, this is a slide from England linked to a report that came out relatively recently looking at some of the challenges with acute psychiatric care in England. And here you can see that 18 patients or 18 people living with psychosis can be supported through an early intervention team. That costs about the same as one acute care bed. So, there are potential advantages if you can manage people outside of community settings, but there are also questions, which is why we continue to have commentary papers and discussions about whether or not early intervention teams are the way forward, or should we go more about providing services and skills within existing non-specialist mental health teams. So what I'm trying to say here is that there are important issues to think about in terms of economic aspects of quality and access. And they're linked, and some of the challenges we identified in our review are issues around funding itself. I've mentioned already that some of the funding is linked to research. That's often time limited. There's a challenge with a lack of mainstream funding. Services being funded by social insurance systems or by tax-based systems. There may be a lack of protection for budgets in countries, particularly tax-funded countries. So that it has happened in England, for instance, that money that notionally is allocated towards specialist mental health services, not just psychosis, but other things as well, is used for other purposes. It's just because there's no protection for those budgets. There may be a lack of guidelines, and policies can also hinder development of services. And there's also practical issues about institutions and how they work. The role of primary care, how that links in with specialist care in different countries. It really works in very different ways. And one thing we were struck by in our review, and perhaps this is a strange thing to say here, but very few of the programs, or only a minority of the programs we looked at, actually specifically cover people over the age of 40 who have a first episode of psychosis. There's an access issue, and as I understand it, it's still about 25% of all cases, first episode cases, are in people over the age of 40. But programs tend to focus on younger groups, and is that an issue to think about when we think about Fidelity as well? So how can we, and this is something for you to think about really in terms of your research, how can you potentially build Fidelity, or the evaluation of Fidelity, in terms of implementation into what you're doing? Well, I'm really arguing here it's not just about the scales themselves, but it's about what is actually implemented, how it's actually implemented. So what can we think about evaluating incentives to encourage better fidelity? So one example that's often used in some systems around health targets, and targets was mentioned in a slightly negative way earlier, but you have a league table publishing how well different services do in terms of fidelity, let's say. Is that a way to go? Could you evaluate that? Would that make a difference? So that's one thing to think about. Financial incentives clearly make a difference. We've heard about co-location or location of services. The way in which they're physically based may make a difference in the way in which they work. What about the surveillance and information systems? If we're talking about fidelity scales, are there actually surveillance and information systems in place to actually record information on the quality of fidelity? Or is it up to individual organisations to decide to do that themselves? So the monitoring may make a huge difference to the actual extent to which fidelity happens. And I would say that what the work that Peter's, the Eden study did across looking at fidelity is very important, because it's also looking at the additional resources required to actually have a greater level of fidelity. Because there also comes a point, well, is it really worth moving from 89% to 91% fidelity? Is it really worth spending the extra resources, the extra time and money? And so it's important to try and evaluate that. And also, of course, take a long-term as well as short-term perspective and think not just about health systems, but wider impacts on top of that. So costing implementation, costing the process of monitoring fidelity and collecting data on fidelity, I think is quite important in a time of tight resources. And it links also, one thing you can find with economics, and this is not for today really, but you can have a program that's highly cost effective, but costs so much money it can't be implemented. Budgetary impacts and cost effectiveness are two different things. So it's important to know how much it's actually going to cost to roll this out, to have better levels of fidelity, to plug the gaps in EI teams so that they cover all the points in the fidelity checklist. They do cover physical health, they do cover vocational and educational services, etc. How much is that actually going to cost? Is it feasible? Is the workforce available to do that kind of thing? And if not, what are the implications of trying to scale up and expand? And a point I've already mentioned, but I'll mention it again because it's important: social functioning. In terms of fidelity, is it also about capturing the impacts it actually has in terms of better social functioning, better outcomes? If you actually invest more in providing vocational support, vocational services, does that actually lead to better social inclusion and employment outcomes for individuals? What impacts does it have on other sectors? Because it may be that those other sectors, if they can see a benefit to them, and when I say other sectors here, I'm thinking, for instance, about ministries of labour or ministries of welfare benefits who pay out money for people when they're unemployed. If you can demonstrate there's a benefit by providing more vocational support within programmes, which means fewer people are excluded from the labour force ultimately, then that may be a reason for them to think more about these programmes. And so you see, this is a very different way of thinking about fidelity in a sort of implementation sense. there are the issues of financial incentives, which I've mentioned earlier. There are the non-financial incentives, which could be about reputation, about rankings. It could be about satisfaction with services and producing those kinds of things as well. But it's really just thinking about what does it mean if we do these kinds of things. What are the consequences if you don't reach a threshold? What are the consequences if you don't actually achieve a certain level of fidelity in your system? And that's, again, coming back to the study in England, which is very important. It's the first one of its type, but it's the first one that's really starting to say, hang on, there are benefits associated with promoting better fidelity, achieving better levels of fidelity. Now, the question is, will that work in the same way in different contexts? And why did they achieve better fidelity in England? Why is it that Peter's service in Cambridge did so well? Is it because Peter and others are really sort of encouraging people to do the best they can, and you wouldn't find that perhaps in some other programs? Well, I mean, so understanding the motivations and the way in which fidelity is achieved is important. So what I really want to say here is, as well, to finish, is while fidelity itself is important, we also need to think about organisational structures. And I will come back briefly to the point about the Italian piano model. The fact there that they've had this large-scale trial about embedding services in community mental health teams with some initial positive results. I mean, that's another thing to think about. Can fidelity be achieved through different models? And we've already heard one of the questions from Canada about fidelity in remote or rural areas. But can we think about how things can be achieved, not just through a standard specialist hub and spoke team, but through other models as well? So I know I've rambled on a bit, and it's a slightly different take on things. And I'm really coming from a sort of an economic perspective, but I really think policymakers and people who hold budgets, I mean, they'll absolutely be interested in knowing about fidelity and quality of services. But they'll also want to know, okay, what difference does this make to the way in which we actually deliver services? If we know more about fidelity, is it going to make a difference to the way in which services are actually delivered? And if not, is there a way in which that can be achieved? And it's challenging because we do have these very different experiences of early intervention services across the world. And there are a whole range of different practical barriers to implementation. But I've really tried to argue here that fidelity may be one additional issue to think about, but to think about in a sense, in a way to try and think about it as a motivating force or a tool to be used to foster implementation and not just simply to monitor the quality of existing early intervention services. So I hope that's helpful. Grazie, thank you very much.
Any questions? We have asked Mirella. Thank you, David. We have asked Mirella to have a discussion. Yeah, could you?
I think that the topic is very challenging, but extremely interesting. I would say that in this symposium there is a lot of epistemology, methodology on how to reach some aim, something of philosophy, and some practicalities. I think that the IEPA board did very well in trying to implement a task force on fidelity. And there were a lot of very, very interesting inputs today. This reminds me a little bit what has been done when community psychiatry was funded. People started to try to schematize which were the most important ingredients, both the places and the content, as it was said before, the content of the treatments and the character that had to be embedded in the places. I think that for early psychosis services, it's very important to have this kind of frame and to, let's say, to believe that fidelity can have somehow an absolute value, which it doesn't, however, because I think that this is the beginning of a process, not the end. So setting certain requirements, both on the physical facilities, on the treatments and on the modalities, I think it's very important to start a work which then compares, as David McDade was saying, the effect, the effectiveness, the outcome, the cost effectiveness of these services. And for sure, fidelity, I think, will never be a sort of absolute knowledge, because the final outcome of an intervention, of a series of intervention, depends on several variables. For example, the context where it is located. So I suppose that one should have sort of fidelity framework for services in high-income countries, services in low-income countries, services with a high proportion of immigrants, for example, services which take care of the specificity of the beliefs of the patient or the persons in that area. So it's a sort of change, always changing concept if we want to have absolute knowledge. Then it implies that we know, and unfortunately we not, but I think it's an aim, is a direction, which really are the active ingredients, let's say the stable active ingredients. In mental health, few treatments are stably active ingredients. So we have to take care of it, of all this, I think, complexity. Moreover, there were, I don't recall the paper and the author now, but there has been some papers in the literature that showed, and this is very much in line with what Peter Jones said, that a too rigid prompt on respecting fidelity, for example, that paper, if I'm not wrong, concerned the psychotherapy, fidelity in CBT psychotherapy, was not producing the better outcome in patients, but the best method to produce the better outcome was conjugating some degree of fidelity with flexibility, which had to be, in a way, documented in its reasons and needs. And I think that this is also another issue. I mean, which is the extent, which is acceptable degree of flexibility when we're looking for fidelity? In which cases this is important? In which cases this instead will create confusion? I'm not sure we all, at least I don't have any answer, but having this framework and do some research using this framework, analyzing when the result of the application of this framework is not satisfactory and when it is satisfactory, will certainly provide good knowledge. Because having a stable framework for us is not probably the end of our work, but at the beginning is very much useful. It is like it was in community psychiatry, like it has been in a way with the DSM-3. Nobody almost is convinced that those were perfect diagnoses, but at least we started to have some common reference points. And also, I believe that, but this is rather obvious, fidelity should never be measured without measurement of outcome, because that's the main path, and we should really worry about putting a lot of effort in having services which have good fidelity without knowing which is their outcome. These are my comments, but however, I think this was very, very interesting.
Okay, thank you very much. Now it is time we must close that. And I think, yes, psychiatry service is very, how can I say, it's very professionalized, specialized, and may be difficult for users to understand what is it. So we have very high responsibility and professional autonomy for checking the fidelity is needed. Thank you very much for your excellent presentation and active participation. Thank you very much.